hope there's no transcribing. That's annoying. Okay, it's transcribing coming up. Okay, should be okay now.
Sur les produits pharmaceutiques à l'OMH.
Oui.
Et non dans le domaine de la résistance antibiotique. C'est pas ça vraiment le focus.
Non, c'est pas le cœur d'activité, mais comme on travaille sur les médicaments de mauvaise qualité,
Oui, parfois.
il y a un lien avec
la résistance.
exactement.
Exactement. Moi, c'est mon topic.
C'est quoi déjà votre sujet de thèse?
C'est arrêtant d'antibiotiques et la prévention et le contrôle des infections.
D'accord.
Voilà.
Mais du coup, sur le sujet de thèse, c'est quoi exactement?
C'est le cytopathète, la surveillance épidémiologique moléculaire, parce qu'on va faire du séquençage.
D'accord.
Des souches patients cliniques.
Oui.
Pour sujet.
Oui.
De cytopathète, parce qu'on remarque que c'est un pathogène qui de plus en plus
augmente. Et à partir de quel seuil vous détectez que ça augmente, etc. Est-ce que vous avez des seuils par pays, par région? Comment? À partir de quel moment un signal est un signal? Vous voyez ce que je veux dire?
Je comprends, c'est une question vraiment très importante. Donc, en fait, c'est juste un trend.
Oui, mais le trend, à partir de quel moment ça augmente un peu, pas beaucoup?
Il faut dire que c'est alarmant. Peut-être que quand vous faites, comme moi, j'ai une grande période d'études. Une grande période, il y a la P-value qui va vous dire, c'est vraiment pour celle-ci, l'augmentation est significative. Ensuite, on va arriver jusqu'à la fin. Dans ce cas, peut-être. Maintenant, un seuil à peu près.
Parce que vous avez combien de...
Il y a une étude qui est nationale.
Qui est combien d'échantillons?
On a 140 contacts. Mais ça, c'est une étude accessible. Après, il y a une étude sur ce qui est 60 000 personnes.
Ah oui.
Parfois, on demande de quelques publications sur
Yeah. So
Yes. Your mind is there.
Yeah, it's very difficult. Please be seated. If this is almost the last session, that's the last session is panel discussion. It's all everything together is to have a few panel members and discuss. Today you can have structured session. See outside of the our last speaker is Harry. Harry is the head of strategy and policy at the law firm. He leads development of law firm strategy and strategy direction, revision the fund application model for direct impact, oversees law firm's key performance indicators and internal performance metrics. Coordinates the secretariat and board level divisions on critical policies from quality ISS to sustainability and climate change. Previously, he served 2 years as director of the global health, both security and development of the National Security Council of the United States. He was the 2010-2011 White House Fellow and Senior Public Health Advisor at the United States Agency for International Development. Prior to that, I served as director of global health and policy initiative and professor level as lecturer at Johns Hopkins School of Advanced International Studies. I also served as author of Signal Conversion CSIS. I don't know if you know that. It's the Global Health Policy Center, and it's expanded with trauma and national security projects. Prior to Johns Hopkins, I consulted for non-PUFs, trust health and security issues. Was a program associated with California and government, and worked as an interviewer and analyst and Baltimore City video exchange bands. Among all this, that's also how you got to field work in Chiang Mai, Thailand, and I'm in refugee camp also. So among all this kind of experience, you can see that he plays a very big role at Blue Fund and the overall global health fields. So welcome.
Thanks, Button.
Yeah, you can stand, you can sit, whatever.
I might sit at, thanks, Button. Nice to see everybody. I might sit at some points because I probably won't be able to read my notes, and I already had a long day. I have a teenage daughter, and so I hope that covers this. A very informal. You guys sound like you've had a ton. I mean, Button just told me about all of the topics you've covered. So very informal. Ask questions anytime. Anything for clarification. Maybe I'll pause after. I've only got a couple of slides, and we can have a little bit more discussion as we go through. And I'll also ask you a few questions. So don't forget that. Is that good? Let's start and go back to basics, because you guys have covered a ton of stuff. So I'm going to, and before you conclude the section of the course, maybe go back to the beginning a little bit. Why do we have pandemics? Like, why are we all here? Why do we have global health? We've got a ton of different types of pandemics, right? You got airborne, you got vector-borne, you got blood-borne, you got iatrogenic, you got other causes, but why? There's clearly a lot of them, right? You've got this slide, which is probably even a little out of date, but every recent new or reemerging, or the one case of anthrax, deliberately reemerging outbreaks. That's a lot, right? And it's always interesting giving these lectures like after COVID. I used to do more teaching before COVID, but now everyone's like lived through this. You don't have to prove the point anymore, but there's a lot. And the risk of an emerging infectious disease relative to the reporting ability, right, also means this is probably going to keep happening, right? There's a lot of risks, particularly
in the States has often been described as an opioid epidemic. And so it's product based. And, some could consider that obesity is, a global issue. And in terms of One Health, it certainly has got an impact on the planet. And it's also because of the way we behave differently to our environment. So our pandemics only, beyond the geographical dimension to define them, does it have to be only for infectious disease, or can it be for non-communicable diseases and or products and behaviors?
Great question. Not nature.
Thank you. When you mentioned that activism increases the public health response for HIV and also for the Black Death, any kind of action was a public health intervention. It's not because more than the public health awareness is the fear for because they don't know to which or to what they are fighting for, because it was the same for HIV. If I'm not wrong, the everything started because no, it was were not aware or they were not they were not aware about gay men. They were aware about the disease because they don't know where it was. So it's fear or is public health?
Fear is a huge part of public. It is. I mean, if you read a great On the left,
Yes.
good effort, but dengue is on the far right. It's actually, it's pretty similar. That's malaria. Did you guys cover a PHIC, a public health emergency of international concern?
We did not talk about that.
Not, well, we need to,
We talk very light touch.
this is a formal declaration by the official definition of an extraordinary event determined to constitute a public health risk to other states through international spread of disease or potentially require a coordinated international response to a situation that's serious. Only one of these, so I told you this is malaria. That's dengue. Anyone know what this one is? Because that's actually the only one that's also been declared a public health emergency. Huh? Good effort, not Zika. Zika was awesome.
Zika was, yes.
Yeah. But polio, older declaration, right? This is Mpox. So why? So malaria, I don't have the stats on dengue at the top of my head. Malaria affects, it's a pandemic, affects most of the world. There are, what, 240
It's the regions.
So who it affects matters, right? Yeah. Yeah. There's, I think I would argue there's a lot of things here. But there's definitely who it affects. So the concept of global health security, very much based in a security basis. How do, my own country talks about it a lot.
Thank you so much. Thanks. So, drink some water. So we'll continue with the panel. We already have panel here. Probably that's Dr. Figo coming once. We'll sit here. So as I said earlier, please sit down. It's coming, sit down. Yeah. Please come and sit down. So as I said earlier, that yesterday also, that's the panel is here to discuss with you. Because a lot of things are still in the process. A lot of things not like really well established yet, especially when we try to link different pieces of global health together. So things are moving. We may not have a good answer. There's something we may not have answer at all. So please try to have challenging, provoking questions. I must say that's at the beginning, that's all individuals here, we act as individuals, not necessarily representing the respective organizations. Please don't cite in any scientific, your PhD dissertation. Say, okay, someone said this, and from WHO, from Global Fund, from Task Force, that's probably for panel members, that's the SEC, that's Dr. Mouse, it's a former CDC employee now with the Task Force for Global Health. Dr. Shiko, it's a finance lead at WHO. And Harry is the director for the policy and strategy. I prepared this question for a while, so little bit that's a little bit provoking. It's a little bit controversial. That's also in the question. We're talking about global health. The first thing I want to say, what is health? WHO got very clear definition of health. It's not only free of disease or infirmity, it's like really the physical, mental, and social well-being, right? So that is the definition of health. And if you look at our health system, it's more disease specific, disease oriented. We're talking about diagnosis and treatment of disease. We look at what Dr. Shiku presented the other day. Look at the prevention out of the health expenditure, minimum. I also read a lot of literature said, should we forget about prevention? Because the entire thing, a lot of things are driven by a lot of other interests, including pharmaceuticals, about medication and the diagnostics of that. And the other thing that Dr. McFarlane, first they presented one interesting figure, if you remember. Around 50% of under 5 mortality reduction is not from our interventions, the intervention we are providing. So that's my question here. I don't know if panel members got anything that's to reflect on this. Are we doing the right thing to achieve what WHO defined something called health? Anyone here, including me, really meet that standard of health, physical, mental, social well-being, not only free of disease. And also the thing that literature also says, who define who is healthy? It's doctor, right? Mostly like a well-trained doctor that define as give you a diagnosis, you are healthy or you have disease, right? So there's a lot of things. There's for example, this health expenditure did not capture something on the prevention side. Probably that's make the environment more conducive for the physical activity to keep us healthy. That part is not a health expenditure report, of course not. So I stop here. The first question is around reflection around this. We're talking about global health, and anyone want to start? Dr. Mars? Huh?
So the question is, what is health?
Then are we doing right thing for the health?
My cynical answer. So I mean, I spent most of my CDC career working outside of the U.S., seconded to WHO and other organizations. And my first international assignment with CDC was in Pakistan doing polio eradication. And if you know anything about the status of polio eradication today, you know that Pakistan is still one of the 2 countries in the world that still has wild polio circulating. So after 6 years there, I walked away wondering if I'd done anything really of value to improve the health of the country. I mean, I like to think we did accomplish something. We established systems that were useful later. But I tell you, there are days when I walk away thinking, when I look at things like what Jeff McFarland was presenting on Monday, where, you know, the things that really make an impact are education of women and economic development. Those are the things that improve health. I sometimes feel like the thing I contributed most was living in a country and spending money and improving the economy, you know, bringing outside resources and buying stuff. So I don't know. I think we do make an impact, but sometimes I feel like the things that we do are almost stopgap measures. They're things that we do to save lives and help make things relieve suffering while countries develop, while countries achieve this other economic development and increases in education, because I think those are the things that really make a difference. And all the other things, I think without those, without the economic development and the educational improvements, I think everything else is just kind of buying time until you reach that. It's not permanent solutions.
Thank you.
That's my cynical perspective.
Okay.
That's great. I've also felt that occasionally, but I'm an unapologetic eradicationist. And I'll be slightly over provocative here just to illustrate the contrast that is available for you guys. Once you've eradicated a disease, you never need to treat another person again for it. You never need to diagnose someone for it. They will never suffer. You can't even graph this on cost benefit curves because you've gotten rid of it, and the cost benefits go throughout the future of human history. So this is extraordinary. We've eradicated 2 diseases on Earth so far, smallpox I mentioned, and rinderpest, which is a cattle disease. But I think a variant of this question is also related to what can external donor funds do? Can external donor funds, I mean, I completely agree with my colleague. The best things you can do is broad socioeconomic development, women's education, rights, broad nutrition programs, social and economic determinants of health. Those are the jobs of the countries themselves, and they face a variety of unique contexts that those countries should decide. That shouldn't be, it's not like my country's done a spectacular job on social determinants of health, right? I hardly think that's our like gift to the world. So I don't think that's really a great role for donor resources, but donor resources in global health can be mobilized for biomedical interventions. They have clear benefit in terms of lives saved, so you can continue to ask countries for money for them, and they can solve specific problems in development. Like if you have a great vaccine, they can get very close to solving polio, and they did with smallpox. And you can do things like put 30 out of 39 million people living with HIV on treatment, so they live and they can love and live and create and grow and have jobs and do what they want with their lives. So that would be my answer. Is I'm actually quite in favor of those types of interventions and eradication. And the nuances may be not that broader social and economic development isn't the right answer, but you can mobilize donor resources for it. And we are in a period of time when you just have vast inequities, and I think we should fix some of this.
Thank you.
Partially provocative to illustrate.
I agree with that as well.
Okay.
Okay. That's a pretty big question, right? So maybe just start on the health. What is health? I think evolving. Yes, WHO back, when they started, they already defined the concept of health. But then you really come to today, and even when I talk about the health expenditure, that's very limited. That's only for health system. And it's only the primary purpose is to improve health. But even that concept evolving. Now we're saying the whole social development is for health and well-being. So in a way, everything, the final purpose is for health, is for well-being. It's not just for I got richer and I can buy everything. If it doesn't create or eat, I think during the pandemic, I think even we feel like that. A lot of people, you have money, and the saving for a lot of people, specifically middle class, the saving increased. But you have money, actually, you cannot even use that money to enjoy that money. So that's also make us to think, what is the final purpose for all this development? Is for health and well-being, right? That's one point. And another point is also from my work, we're saying, the health, health expenditure is too narrow. So what is counted as health? We always say, health services, your payment is counted as health. But how about for the cosmetic surgery? This health or not? And obviously, I think most of us say, no, that's very clear. No, cosmetic surgery is not health services. But health is not just you get some disease. The mental well-being is also health. If you don't make my eye whatever or remove this wrinkle, I would just cannot be functional, have my mental problem. So then I do that, even though it's cosmetic surgery, but it's so my mental problem. Is that health expenditure or not? So that's all, all these things trigger us to really think deeper. But of course now, the socio-economic beyond health. And I also agree in the economic development, the basic living standard, just the hygiene, water and sanitation, that saves a lot of life. And that cost is very often is not counted as health spending, right? So that's something in terms of the concept of health. And perhaps I also want to follow up on this, what the global community, what the development partners can do, what the health aid should be focusing on. We always say, we should fund to the country to filling the funding gap. But on the other hand, we're also kind of criticizing some recipient country to say, oh, you didn't put enough money. You're funding the correct thing. But if the partners, if the donors, you fund the most cost-effective things in the country, so what the government should fund? So in a way, who should fund on what? If our purpose is filling the funding gap and eventually make this funding sustainable, and country can pick it up by themselves. So who should fund what? So that's one question. The second question in terms of the aid is now, we're also very much emphasize this global goods, regional goods, or common goods for health or on health impact. So then you only have certain amount of money. How that transition would be minimized, the negative impact. That yesterday we mentioned some countries, 30%, 40%, 50% of total health spending is from external aid. So now in this transition, how can we handle that? The donor funding is very much determined by the donor government also, right? So today, this year, I gave you 3 billion. Next year, I gave you 2 million. That's huge. difference. So how country can cope? How can those aid be predictable, have a long-term kind of transitioning out? That we also say why domestic financing is so important. Why we try to not rely too much on the donor funding. So I think that's also some questions that I ask myself, you know, what do we do? How do we build the future external aid paradigm?
Thank you. You already see that's different perspectives, different angles to look at this. As my reflection is more like as a human being, we are talking about human health. At the very beginning, I already talked about that. So we're not talking about animal health and other things in the One Health agenda. There's a human health. Well, people, anyone, individual, first thing need to born healthy, and then survive, strive, and then getting to this life expectancy, being healthy. We talk about daily, right? So it should be disability free, disease free, and be healthy, and all this kind of thing. And the people will need to have job, get educated, move to different places. If we talk about people centered, how the system will help the individual in any place to keep them healthy. That's the thing I don't know. I still have doubt if the system now actually support that kind of thing. Of course, the other piece is you cannot talk about just health system without talking about entire social structure and environment. That is not possible there. So I don't know if we will have a question, the answer on this or not. We'll come to you guys. Okay, have some little bit wide discussion on this. But I would like to raise the second question. Then we open for all this kind of thing. Second question, I spent a little bit time also on this. So naturally come from Harley's this external aid and Dr. Shiko's external aid, and also that's what polio have been doing, try to finish the job for 100 days. So we have a kind of the national health system there to serve the purpose to people like when in need to get diagnosed and get treated and all this kind of thing there, the system there. But that is more like especially in the primary health care units. We talk about that in first day. But it's more integrated, right? We call integrated. But in between, we have something because it's urgently we need to address something like HIV because people are dying in large quantities, or during COVID, we have this. We need the specialized program. So the specialized. So with external funding, like a global fund is doing HIV, TB, malaria. So people say that we created vertical program. Vertical. So this specialized program has its own purpose because we want to focus our effort to tackle certain issue in the quickest manner, that's to solve the issue, that's to save people's life in the way. But when we be specialized for a period of time and then become more specialized and try to do things better, quality, and demonstrate results quickly, and all this kind of thing will come in, right? Performance-based funding, all this kind of thing will come in. And there will be all this specialized program, you will need to find foundation of the integrated service platform. So my question here, where are we in terms of this between specialization and integration? So I know there's no one fits for all answer for this. What are those general principles when we do this? Global Fund, Gavi, we are like created because of MDG, because MDG at that time, I think the people talk about that, where MDG from. It's more like a group of experts come with the SDG is more consultative, more inclusive. The process come with SDGs much more far-reaching in terms of society and all different development areas. So my question is, are there other tools and mechanisms, including funding and supporting this between specialization and integration. So I let panel members talk first. Anyone want to talk? Okay.
This is one that's kind of near and dear to my heart because I see both sides of it. I agree that, I mean, for eradication programs especially, you got to have specialization, you got to have focus. And there are a lot of really high priority problems out there that unless you get very focused on fixing that problem, you're not going to beat it. And integration, too much integration just dilutes your effort. But I've also seen the negative impacts of these vertical programs that are started by donors. I was in Southern Africa recently, and I won't name the country, primarily because I can't remember which one it was, but we were working on helping to strengthen surveillance systems at the community level, working through community health workers. And what we found was there were like 4 different cadres of community health workers in every single community. There's one, her only focus is antenatal care and maternal child health. There's another, her focus is nutrition. There's another, her focus is something else. There were like 4 different things. Each one was created because a donor came in with earmarked money that said, okay, we're going to focus on nutrition right now. And what you find is they're siloed. They can't work across. They're not allowed to work. They don't feel like they're allowed to work across these. The government there was actually taking a very thoughtful approach. They were going to forget about all the silos. They were revising the entire program and thinking about what are the things that we need community health workers to do. But it was a strong national government that took the lead on that, and it kind of pushed back against the donors. But I've seen this over and over and over again. Donors come in, lots of money. They say, we're going to do this. And, you know, for my polio experience, we had to protect all the vehicles that WHO bought for polio. We couldn't afford to let those be used for everything else because we needed them for polio eradication. And if you start pulling away resources from polio eradication, polio explodes. And so somehow you have to find the balance. I don't know what the balance is, but getting donors to talk to each other would be a good start, I think.
Who will come next?
You go ahead.
Okay. I think that's a really good point. And we didn't talk about it, but we could have in the malaria section and in other sections. There's a very strong colonial history of global health that continues to this day. Right. One of the schools I went to was the London School of Hygiene and Tropical Medicine, founded on the Royal Albert Docks. And why was it on the docks? Because that's where the ships came in from the colonies where British folks got sick, extracting resources and doing other bad things in West Africa and the rest of Africa. A lot of global health history is driven by that period of time to protect colonists when they were extracting resources from colonies. So a lot of that history comes in. You see remnants of that with the donor-driven debates mentioned today and the donor-driven resources. I'd say a few counterpoints to that are worth considering, though. One, I totally agree. It's a country-driven decision, and you see a number of countries, happy to name, there's some autocratic countries in particular, Rwanda, Ethiopia, Vietnam, that have been very clear and just said, thanks for your donor support. This is how we'd like to organize it. This is how we're running our health system. This is where I want you to plug in, you to plug in, and you to plug in. And you get some terrific health systems impact in that way. Whether or not you can do that in a car or a country that's just had a coup in West Africa, I mean, there are limits to what you can do with that. But it is ultimately, I think, the country's responsibility to run their own health programs and support the health of their populations. The second thing I think to consider is that diseases can cause an unbearable burden on health systems. We saw that in Northern Italy with COVID, right? The Northern Italy health system basically shut down as that first wave of COVID hit in 2020. In Nigeria, some 60 to 80%, in Kano in the north, some 60 to 80% of hospital admissions are for malaria, which is an analogous situation. How is that health system supposed to meet the full health needs, the physical, social, and emotional health of its population when 80% of the admissions are for malaria, kids are dying, and you don't have enough hospital beds, right? If you can knock down malaria with a campaign there, that is probably the biggest investment you can do to improve the capacity of the health system there. And the third thing, I'd just go back to the point about what we can raise funds for. We have had a health for all by the year 2000. You've probably noticed that didn't happen. That was the Alma Ata Declaration. The history of raising generalized funds for health, while I agree it's the right answer, it's the right intellectual answer, it's the right emotional answer, the history of raising additional funds for health, and we do need additional funds today, like countries with debt crisis, with climate change, with conflict, there is not like a vast increase in domestic resources in most countries for health available today. So if we're going to raise, at least continue donor funds for health, and we're in a real pickle right now, right? Gavi's having a replenishment this year. WHO is doing an investment round, which is basically a replenishment. IDA, World Bank IDA is doing replenishment this year. The Pandemic Fund is doing a pandemic replenishment this year, and the Global Fund's doing one next year. There's a huge competition and demand for those funds. We have historically been able to raise funds for well-designed disease programs that show impact. I'm worried everyone wants to pivot to broader health systems funding. And that's the easiest thing for donor governments to say, that's great, we gave you enough funding. There's not really great metrics for how we do this, and this is really a country thing. We think we're done now. We're gonna pull back funding. So I think all of us in these institutions are quite worried about that transition. It's not forever. The future of health financing in all but the lowest income countries and conflict-afflicted fragile states is domestic financing. It's not donor financing. The Global Fund won't be here for 30 years. We're going away, right? We may have a continued role in the lowest income states and fragile states. But how we get to that transition period and whether or not we can continue to raise donor financing, I think is a real question, relevant on your question.
Thank you. I also quite agree with both what you're saying. You know, if you think of how this vertically funded program started, it's not just because of the Global Health Initiative. It's not just because of Global Fund and Gavi, and then you suddenly have all this vertical funding. I mean, I'm from China. Here I have an expert in China. Perhaps I shouldn't say that, right? To use China as an example. But what I see is in the early days, in the 50s, 60s, there is no such thing as a global fund. And that in that sense, Japan, Korea, also, there is no such global fund or whatever fund. But the TB is very prevalent. So the government actually have vertical funding, vertically this program, because as you said, suddenly, you know, you have all this 80% population, all because of this one disease. Of course, you want focusing on this disease. And the most efficient way is to kind of concentrate, you just do this, you have specialized clinic hospitals just to treat this disease. But now, I think of it now, the situation changed, right? It's not just because, oh, now the health system and everyone should fund the general health system, but the disease pattern also changed. The epidemiology is also changed. So it's not the best way, it's not the most efficient way anymore in that sense. So the transition is not just because, oh, the donor forces and now we want to, you know, come back, whatever. It's also the disease pattern. I think that we also had to recognize. And at the time, Global Fund established, if without Global Fund, do we have today's level of control HIV? Yeah, I would put a big question mark, right? That's a marginalized population have that disease to start with, and government will not put the money on that, right? And also on Gavi, and you know, the vaccines, all these vaccines for those diseases, for the infectious disease for high income countries, not relevant to them. You purely have no market. The pharmaceutical company will not develop those vaccines. And that's also one of great contribution Gavi established. You basically established the market for the vaccination. so that you have this vaccination you know, for the more kind of low and low middle income countries. So I think we cannot disconnect the context when they started. But now what we're talking about is like you also recognize it is really true. You go to a health center, I don't want to mention the country name either. So you go to a health center, you have a 3 microscope. One is from Global Fund, one is from PEPFAR, one is perhaps from you guys, from Gavi. So why we need that? And each one you have that, why you need that? And you go to the national program on HIV/AIDS, they have 20 people sitting there doing the financing, managing the financing. And you go to the Department of Planning and Finance in the ministry, there are 5 people working there in one dark room. So you know, when you see that, I mean, and then you see the 4-wheel drive from nurse, you go down to yes, you will do the vaccination. Yes, you will do things, you go down. In the meantime, there is no ambulance in the country. So all of this is also trigger us to think of it. So how can we somehow strengthen the overall system? So a lot of things, perhaps the overall system can pick it up. And you go to immunize the child, perhaps you could also try to have some consultation with pregnant women, that prenatal care, you can pick up on that. Perhaps you could also do some nutrition interventions. So I think that's what we're talking about. The challenge is really very difficult because when you have some program reach some poor, the rich one always don't want to give up, right? So of course I want good computer, I want nice, you know, office, I want 4-wheel drive. So when I wanted, I go down to any village. But on the other hand, if you don't have the system as your foundation, it's very difficult you can sustain. How about one day there's no money? And I think in the sense, the country, the recipient country also need to make some effort, because it's obviously in some countries, you also face the public financial rules. If it's donor money channeled directly through the program, is separate from the national public finance management, you can contract doctors, you can purchase things. But if you go through the government, you cannot contract, you cannot hire staff. So that's also quite a lot of loss in a way. There's a lot of those details. And then you say, yeah, we say, you know, Vietnam doing well, you know, on the transition. But at the time, in 70, we say, okay, the HIV treatment should be covered by the health insurance. Yes, but the health insurance require ID card. So in order to get the treatment, get the services, you need to reveal your real name. And if some people have actually, they don't want to, then you don't get the treatment. So it's not like just to see, oh, at the surface level, this is right, this is wrong. It's not as simple as that. It's a lot, the context, and we really need to understand so that we can really help them to move forward.
Very good, fantastic. That's also another this a topic that's with so many perspectives and reflections on this. My reflection, I'll tell you, that's we're open for this group discussion. There's one thing that's or any specific disease or any health facility, not all service items are integratable. Some need to remain to be specialized. So when we talk about the integration, it's not everything. I use HIV example. This Dr. Shigo already talked about this. The ARV, ART at part of the health insurance program probably have barriers. I give example this for the HIV prevention for key populations probably can never integrate. You need to remain something specialized for that. Otherwise, it's not possible. So that's the one thing I reflected. The other thing is this. It's a very interesting phenomenon, still very prevalent in many African countries. We have these different doctors, different nurses, found by different. It's not they want to be that way. because we have legal agreement. So this money is for this. This money is from this channel for this. So in the meantime, we made that happen. And then in the meantime, we ask this, can you work together? So that is too naive in a way. So how we can, among donors, among all these development partners, just have this kind of alignment, harmonization to make this happen. One microscope can be dual use, multiple use, and in the way so how can we make that happen? So saying this is a lot of the architectural things need to happen in order to make this really happening on the ground. The other thing is people also mentioned about other panel members mentioned that national leadership. Why Rwanda, Vietnam, that you give examples, they can do this. Why not the other country? Of course, they have other political and other contextual issues. But I think this national leadership in this, they have a clear way how I deal with the health issues in my country. How can I optimize the limited resources and the capacity in my country to better serve the people in the country? So that is also this thing that we need to, and also from the global development partners, how we can empower national government and Ministry of Health to make those things happen. So that the thing is, of course, we do not have one answer for everything. A lot of things need to be context specific and need to be differentiated. That's in the way. So we open now. Could you help with Mike? So people around these two aspects, or that you can ask other provoking questions. I suggest at the very beginning, and please feel free, but don't need to go through this kind of really something very specific. You can use that example, but we need to talk about little broad issues. Any? Okay, please.
Yes. I thank you very much for these very interesting insights. I especially appreciate the insights from Dr. Xu. I hope I'm pronouncing it right. We're all talking about funding and funding of needs-based interventions, evidence-based interventions, and that's basically the policy and science interface. Not a fan of politicians, really not. But the scientific community, we probably also need to look ourselves long and hard in the mirror. We are also probably very responsible, I think, for orientating the way in which politicians decide to support investments in one way or another. There's a really good book that I recommend to everyone called The Wisdom of the Horse, that's written by Elizabeth Pisani, and that explains really, really well how during the HIV golden years, I would say, on lots and lots of funding, well, you'd beat the drum wars saying everyone's going to get HIVs. All these very law-abiding housewives are going to get HIV. Their children are going to get HIV, and that will scare people, the fear factor, into putting loads of money into HIV. It did not happen. It did not happen in certain regions of the world where the sex partner patterns were not disposed for that. And we're responsible as scientists for promoting and communicating about this. And there's lots of evidence base. Ask even you as panel members. I could ask you, what's the biggest global health priority that we should put our money in? Maybe one's going to tell me AMR, another one's going to tell me obesity, someone else is going to tell me something else. And we can't even agree even amongst ourselves. So as at WHO, and I'm sure everywhere else, when we go out to see donors, we're basically lobbying. Please put money into this. Please put money into that. And we'll piggyback on all sorts of things. And sometimes because the reporting mechanisms of the Global Fund, of Gavi, of UNITAID, of WHO, of the World Bank are so complicated, it's easier to say, yes, we've paid for microscopes. Yes, I've paid for a communication campaign that had zero impact, because we all know that communication campaigns don't have any impact if there's no acceptable alternative. People won't change their behaviors if there's no alternative. But look during COVID, how much money was put into communications. So I fully agree with everything that's been said, but I think that on the science policy interface, we've got to judge ourselves as well, the scientific community, and Yeah, I think we've got to also talk about data governance. There's been a lot of progress on the publish or perish approach within the science community and sharing a little bit more. So I think, yeah, we've got to we're part of the problem and therefore we're also part of the solution. And just one final point, I find it really interesting that on all HIV interventions, we kept mentioning Global Fund, but not one word on UNAIDS. So I don't know what that says. The wisdom of the horse. So it's called
Wisdom of the horse. I have that book. Horse, the sex worker, basically.
Yeah, and it's free. And
I have that book.
Data collection.
The Pisani signed that for me. I have that book. Yeah. It's very interesting perspective. Thank you so much. That's the one of the complicated thing is the health issues so diverse. There's so many of them. There's so many. And it could be like for you, for me, I have different perspectives. I have my own issue, you have your issue. I know that's even that's among science community, that's a public health, global health community, it's not easy, but we know what are the major ones. I think that is clear. The major ones are clear. But the thing is, in a way that people use this as a tool to lobby this another context. Because some like a geopolitical and also the established relationship, all this kind of thing will influence a lot of things in terms of funding flow, where we put more money and then that's my let's get to some more and then we have panel members to reflect also, please.
Yes. Thank you very much. I think we're speaking the same language, and as it has been mentioned, so many of these organizations are now launching replenishment conferences over the next years. It seems the flavors of the year is pandemic preparedness and climate change. Last time it was gender and equity. I would like to ask you, from your individual perspectives, if you had the opportunity to reset the current global health architecture, what would it look like?
Wow. Okay, please. We continue. We'll try to reflect later.
Sorry, I wanted sorry, as an independent health researcher and education for kids, like what COVID is bring to your first question about what is health and are we spending it in the right places? I mean, I come from Switzerland. I don't have much experience in other developing nations, but it has brought forth, has amplified this issue with trust in public health now. Because what happened with the communication campaigns, with the fact that it seemed to be very much fear-based and not educating the public and how they can protect their health, is now there's frontline workers are really questioning everything that comes out of the WHO, comes out from the authorities, because that trust has been broken somewhere. Like we spent so much money with COVID, but now we have this mental health epidemic. We're having much more social costs as a result. Children, I mean, the impact we're going to see for generations. And as even the WHO, it feels like their initial job, they can't do it properly anymore, because when they receive funds, it's earmarked for specific things, and they no longer have the flexibility, and they have to answer to their donors. They have to answer to Gavi or Bill and Melinda Gates, whoever it is. And the crisis in confidence, I'm concerned that people aren't going to take public health policy very seriously anymore. I'm generalizing, of course. But how can we rebuild the confidence? Because that, like, if you don't have people trusting in the public health authorities anymore, and you don't, for instance, next pandemic happens, no one wants to, get in line to do the contact tracing, whatever, because they're worried their data is going to get stolen or whatever. What are the strategies that we can do to address that, which seems to be a real problem as well on the frontline healthcare workers?
Very quickly in this line, yesterday, CARE presented the figures, right, about the expenditure, and we've seen that, in fact, the governments are, early figures shows that the governments start spending less, right, in this upcoming years, in the upcoming year. And what should we do? Because how we make sure that the policymakers try to allocate more funds for the health sector. And do we need to have another pandemic or what? Because during the pandemic, yes, that was very much a lot of money was put right into the system, and now we see that. Of course, there are lots of emerging problems, conflicts ongoing, but politicians just saying, government saying, yes, health is important, but at the same time, the figures showing different. And as you were rightly saying that the trust has been like lost, there is no trust probably like in their all the what happened. So what should we as the researchers and what should donors, partners do in order to, how to say, to make the politicians to think more about the health and not just saying, yes, 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 it's important. And not only, okay, so we are going to give the money to Global Fund, to Gavi, so they are going to solve their problems.
Thank you. Let's let panel members reflect a little bit. I think that's one of the things about this. If we redesign this global health architecture, what it will look like. Okay, that's very important aspect of this. The other thing is how we can really maintain the health on the global development or global agenda. So COVID eluded a lot of things. The trust. Probably people already see the worst scenario. Nothing can be worse. Any pandemic can be worse than COVID itself. So the politicians already saw that kind of thing. So, okay, how can we maintain still the health on the top or the high on the agenda? That's the thing. So I let the panel members reflect on this. For your question, I think the health on the agenda first before we can have other priorities. Anyone want to go? The panel.
Restructuring the global health architecture.
No. So that's any panel member want to reflect first. If not, let me try it first. I think that any organizations, probably at UN organization, we're always good at creating those organizations. We're not very good, not good at all in closing any. So that thing all this kind of thing that's organization or initiative or created because of the reason. We have a strong justification to create that. And we do not have a plan really to phase out. We do not have end date, say this by when we need to end, under which condition we should end. That we do not have that. If we can reflect now, probably we need to have that, is my reflection.
This is related to your comment also, is you mentioned seeing Global Fund go away in 30 years. What does that look like? I have my doubts because of exactly what Button was just saying. I think it's 30 years from now, Global Fund, somebody who doesn't want to lose their job is going to say, we need to expand our focus because now this is a priority. There's lots of funding out there for this problem. Let's expand to, and we do that within my organization. We're seeing mission creep in my team because, the team I lead, task force was set up to support introduction of COVID vaccines. Well, we can't give them away anymore. I mean, nobody wants the COVID in the countries where we're working. So we're expanding our focus. We're looking for where are the resources now? And
thank you.
So we don't have an exit. We're not planning to shut down our program. We're going to look for more funding.
Okay.
What should it look like?
No. Already draw. That's a blueprint. 我在上课呢，讲课，在讲课。
If you drew, no one in their right mind would draw the global health architecture the way it is today, right? I mean, no one would. If you had a napkin and you were sitting at the table, you'd probably start with something like this: WHO essential normative role and bringing together member states. You need funding organizations that can responsibly deploy funds and track measurement and results. Gavi and the Global Fund in particular have developed over time to be able to do that, justify results, continue to raise money for it. And you need a lot of technical advice and support. CDC, bilateral agencies, UN agencies like UNAIDS and others, really critical in that. So you'd probably, you might start with something different, but it'd be something simpler than what you have. You would not have Global Fund, Gavi, CEPI, FIND, UNITAID, Pandemic Fund, multiple others. But the really practical question is, how do you get from here to there? Right? And we are going to have all the organizations, you're exactly right, are feeling a tremendous amount of financial pressure. UNAIDS in particular on its budget. FIND just laid off a lot of people. And what I fear the pandemic accords are not, at least yet, coming together to say, hey, we've taken this really seriously. This is the way forward. This is how we want to treat pandemics and broader health issues seriously. What's likely to happen is those decreases are going to differentially hit organizations, and some are going to shut down or go away. They're trying to expand their mandate and work, but we're in a really dangerous period where things could just fall apart. So the question isn't necessarily what it would look like. I think it's how do you move from here to something better in a way that's not just donor funding cut driven. I do want to pick up the politics questions, which are super interesting. I agree with you that public health professionals have a role to play. I've spent a fair amount of time on the political science interface, and it's really challenging because science kind of understands things based on evidence in the past, and politicians want answer to future issues. Politicians also, by and large, are not people that studied science. There are some good exceptions, but mostly they went to university and they were like, I don't understand any of that. I want to do something different, and went away from it. So there are, when you brief heads of state, there are cultural barriers, there are scientific literacy barriers. Actually, the new head of Gavi, Sania Nishtar, is a fascinating, she's a Pakistani politician who does understand, who's run the health system and understands the difference between like efficacy and effectiveness. I was enormously impressed, but that's an exception. That usually doesn't happen. So there are those cultural barriers between them. And also, if you want to meet with a head of state, you've got to get on the agenda. So I agree with you about the fear mongering can have really negative repercussions in health. At the same time, when I worked in government, we referred to some of the like doing good things like polio eradication as the positive agenda, which got maybe a meeting a month in a place that held 100 meetings a day. Right? Like so there's a lot of challenges about that interface. I do agree we've got to look at ourselves, and some of the best communicators in public health are really clear and cautious about here's what we know, here's what we don't know. But they're being pushed out in an environment of TikTok and Twitter and increasingly autocratic regimes that don't care about science, that want to push other interventions. I can tell you the political party affiliation of people in the United States by their vaccination rates, right? And that's an environment in which public health communication is just, I don't have an answer. I'm not sure anyone has a good answer, but exceedingly difficult. So just a couple ideas on that, but you guys are going to have to work it out. I don't think anyone's got the answer there.
Well, I don't think I have the answer what it looks like. And I feel perhaps that question is really remote now, where we have already been very far to go back to a white paper to just draw whatever we want. I think at least my kind of personal perspective is now, as everyone's saying, you have all this climate change, pandemic funds, something else. So you further fragment. So if we say we can't really go back, let's not talk about closed global fund, closed country, that just even not mentioning that. Are we not creating new ones? And can we, with the existing ones, can we somehow work together and not make it a vertical? And and then otherwise we're competing to each of the program. Health is important. Well, health is important, but my program is important. Is more important than yours. You have that situation. Is very hard to move forward.
Thank you. Let's open for another round of comment questions. And
I just like to quietly shift the track. Like pharmaceutical commodities have the major share on the health service utilization, and most of the donor agency, they are not prioritizing pharmaceutical service in terms of quality assurance or local capacity building of pharmaceutical manufacturers. Is there something hidden interest of big pharmaceuticals under that? One, and another one is there is increasing prevalence of substandard and falsified medicine in lower and middle income country. And people are purchasing most of the pharmaceuticals through out-of-pocket expenditure. That condition, international is WHO is doing somehow result dissemination. But is there any other organization who are working on transportation of pharmaceutical between countries? That's my question.
Thank you. It's
Okay. Thank you so much. So just I have two questions, not necessarily related to what has been discussed. One is I'm thinking about when we say on a holistic health approach, like mental health. I'm feeling like we ignore the spiritual aspect and the role of like the religion to be part of the table, and even donors. Like if you engage some religious aspect to provide, or you are not allowed to go. But when you go there, actually still there other stakeholders who have a lot of clients go there, even they have impatient prayer camps, even people will be admitted as if like a modern science. If you are thinking about people-centered approach, we should provide the service where they are. If they are not coming to, so how do we like even design this global health issue as part of like how can we engage the spiritual aspect? How can they help to shape the behavior? Because they will work against us actually. We have seen a lot of incidents during COVID. What happened? Because they took their follower and serve him and give some medicine and die immediately. So I think we are focusing on the science. Well, we are saying this is how we go, but without engaging them, it will be hard. And so what will be the thinking, like especially this global health or public health, normally being mentioning spiritual health, but I didn't see any formal engagement and to use and maximize the benefit. And the other, just to say a comment on the previous side, on this vertical issue. Actually, it's not a true vertical program when we say, I've seen some countries in Africa, it's not a true vertical. You will find a special program at national level, but at service level, seamlessly integrated. The same doctor do malaria, HIV, but the money is coming. So the money, global fund money, may be support to buy TB medicine if it is TB, but others are seamlessly integrated at facility level. So it is a sort of hybrid. So that type of country, somehow they are resilient. If withdrawal comes, like only financial, but in terms of capacity, it is there. Thank you.
thank you. Please.
Yes, thank you very much for the great discussion. That's been very interesting. And then I basically agree with the overview that have been addressed, particularly for the point that you can mention that whether we should go for more specialization or integration. I think it's depending on the country, really, depending on the country and also depending on the view of the government. Because I work for WHO, the Eastern Mediterranean region, and we cover all the Middle East and also northern part of Africa. And I work under the Health Emergencies Program. So we go into those conflict zones all the time. And then what we have been observing is that so we spend enormous amount of money and effort to build the health system and also the better health services for all. And then once conflict occurs or recurrent, that everything is destroyed all at once or long-term consequences. And then nobody can deny the negative impact of conflict and wars. But are we making enough efforts as a global health community? As you have mentioned that it's very hard to communicate with politicians sometimes because they don't have a scientific background, but are we making enough efforts as a global health community? Because on our first day during this spring school, that we had a speaker, I'm sorry, I forgot his name, that he did the session about the global health diplomacy, right? But yeah, but we cannot detach global health diplomacy and also the politics from health, from global health, because in our region, it's basically the negative impact and it's a direct and indirect and also the instant or long-term consequences. Nobody can deny this negative impact of conflict and war. And I think we should make more the unified voice, the efforts to fight against war, and also more. We have been very passive about the conflict and war because we keep saying that because it's politics, and then it's we cannot do much about it. But I think when we are more unified together, we can make a better change, I think.
Thank you. Probably that's we have panel to reflect a little bit because we will need to conclude soon. That's about the time. So a few points here that's made. That's anyone want to reflect? It's among those.
It's about the role of religion in polio eradication in Pakistan, if you don't mind commenting.
No, it was huge, but I've never been convinced that it was really about religion. I think it was politics and politicians using religion. We saw the same thing in Nigeria. Nigeria was, along with Pakistan, Afghanistan, and India, Nigeria was, when I first started, the fourth country that had endemic wild virus circulating. And Nigeria is a country that's divided along religious lines from the north and the south, north predominantly Muslim, south predominantly Christian. And what you saw there was politicians using religion as a way to gain favor, to gain advantage. And I saw the same thing in Pakistan. I was never convinced that the Taliban really didn't believe in polio eradication. What they wanted was power over the central government, and polio was a huge priority for the central government, the national government. And so the Taliban used that as a tool, and it was very depressing to watch because they used to spread rumors. This may be a little sensitive. They used to spread rumors like, polio vaccine is a tool of the West. It's going to sterilize Muslim children, and it's being used by America. And I thought, if I really wanted to hurt Muslim children, the thing I would do is try and convince mothers not to vaccinate their children, which is exactly what you're doing, and I never was convinced that people believe that on religious grounds. I think it was politicians and people that were looking for political power who were using religion to manipulate people. We see the same thing happening in the US right now with COVID. Prominent politicians manipulating religious groups against COVID vaccines, against masking, everything. I think we see this over and over again. I'm not, when we got religious leaders to work with us, it was really powerful, but often the politics would undermine even those efforts. So it was never clear what was religion, truly religion, and what was politics.
I just echo thank you for sharing that. Those are fascinating cases in polio eradication. What you said as well, meet people where they are, I think is a tenet of harm reduction, which I've worked in a long time. And that's what you have to do. So whether or not it's religion or other aspects of their lives, like if you want to improve people's health, it's not about telling them what to do. You meet them where they are and you serve their needs. It's relatively simple in that way. But of course, really complicated. I might just pick up the questions you raised on pharmaceutical companies, and I'm glad this is not for attribution. I don't know the answers to all of them. I don't. Others can comment more on the substandard medicines and transporters. I mean, pharmaceutical companies play an enormous role in global health. There is an enormous role in terms of the COVID vaccine inequities played by pharmaceutical companies seeking profit. They have an enormous influence on donor governments because they contribute to political campaigns. in countries. It's not a new issue. When I was reviewing some of my notes on malaria, the competition for the chinona bark, which is the precursor to quinine, which was the first treatment of malaria, and the desire of colonial countries to get their hands on it, produced, I think, Peru, South America, was enormous. And they would just sort of steal seeds and graft them onto other plants and then use industrial processes to try and produce it so you didn't have to grow it. And that isn't terribly different than the pathogen access and benefits sharing debates we're having in the current pandemic accord. So pharmaceutical companies also play a huge role in terms of no one else has the know-how to conduct large phase 1 through 3 clinical trials amongst huge populations and prove, and devote time, resources to which new products could be potentially useful or which new vaccines. And as we talked about with Gavi, and you mentioned creating the market, there's not a huge market for diseases of poverty. There's not a ton of Western pharmaceutical companies that are like, hey, let me go try and find a cure for a disease that affects people who live on less than $2 a day, right? That's a failure of our world. There's a number of push and pull mechanisms that have come about them, but they play a really important, both positive and challenging role in all of global health today.
And maybe just pick up a couple points. On the pharmaceutical ones, there's a book written by the Pfizer CEO. It's called Moonshot. How they within 8 months developed this vaccine, the whole politics at the global level, and it's a quite interesting perspective, and I think that's interesting to read. Perhaps just also on the religions, but maybe from a slightly different perspective. Also, the function, the role of the religious leader to play, but also there's a lot of faith-based facility, like in Papua New Guinea, and that country is maybe half or something around that size, that scale is faith-based facility. So they do play a very important role. In the way, I think someone mentioned earlier, it's the trust, right? If they trust that the religion, it is people's belief, right? You trust it. So perhaps that's also playing some kind of impact why people want to go to the faith-based facility. And I think, again, then how government can strengthen them, right? If they're doing something good for the community, for the people, then it should be really strengthen them, try to improve the quality of the services. And the last point I want to mention is on this, the politics and the science. And I think, in the way, it is true, the science you should be trying to seeking the truth, right? And specifically on social science. But here, I think most of us is social science, and being social scientists is very hard to say this thing is absolutely right or that is absolutely wrong. It's very much context based. However, there's still some objective views in it. So I think, working in the social science on the policy kind of dimension, first of all, you still want to get the science right. Then you're talking about the influence and how to implement it. If you mix together the science, when you're creating the evidence, you already have something in your mind, and that's also very dangerous. That's not evidence-informed policymaking. You basically generate evidence for the policy has already made. So I think that's a dangerous territory we don't want to enter.
I want to laugh about this, the evidence-based policy making or policy-based evidence generating.
Can I comment real quick? I'd say the evidence is in that evidence-based policymaking does not, by and large, happen. Just want to be clear on that.
So it's a policy-based evidence generating. Okay, so I will not go that. I want to comment on the conflict thing that's in the war. That's when a lot of this health issue got this trapped in this big political and geopolitical and the war, this conflict. It's very difficult. And I don't think we have a solution. But I want to end up this panel discussion with a positive note. In Ukraine, that's even during this ongoing war, we managed to continue the service delivery. We, in my response to one of the questions around AI, actually the Ukraine has over implemented as in country use AI to provide prevention services. And they also changed the structure also from Global Fund side, we changed a lot of things in order to ensure service continuity. That's on that. So I think there's a lot of things still can be. We talk a lot about this, a lot of things here. That's mostly like issues and how, but we do have a lot of good practices in a lot of places. A lot of things we do not have answer. Why we keep debating, why we keep talking about that? Because we live with the answer. We live with the answer. So probably now we do not have answer. Probably next year we will have answer, or probably in 10 years we will have answer. So that I think that's we live with the answer. Just because not because we want to debate. We want to make this more clear. This so over 3 packed days. I thank you so much. I learned so much. I hope you learned something. If you learn something, we already achieved a lot. I want to thank the panel members for their perspectives and all this kind of very insightful opinion around this. There's no like one size fit all, like a solution, correct answer or wrong answer. There's no on that. And also thank all these presenters, or not all of them. They usually presenting all the presenters. We have 18 of us. Can tell you that I approached like over 100 to have 18. So that's a lot of you guys made a lot of effort also. That's in order to make this happen. Thank you so much. Thank you. Thank you. Thank you.
So we have.
They still have other things to continue.